Hello, everyone. My name is Hanan El-Hammami, and I'm an undergraduate student at UCSD. I'll be your facilitator today for this breakout session. Please allow me to introduce Dr. Pranav Garimella. Um, he is an MBBS, MPH, and is a board-certified nephrologist who provides comprehensive care for a wide range of kidney diseases. He has a special interest in polycystic kidney disease and is the founding director of the UC San Diego PKD Center of Excellence, which was designed by the PKD Foundation as a national leader in multidisciplinary PKD care, research, and education. He also serves as Chief Medical Officer of the American Kidney Fund and co-chairs the PKD Foundation's Centers of Excellence Advisory Panel. He completed his fellowship in nephrology at Tufts University School of Medicine, Tufts Medical Center in Boston, and his residency in internal medicine at John H. Stroger Junior Hospital, Cook County in Chicago. He earned his medical degree from
Indian is good. You don't have to say what.
it's so hard to say, but please allow me to introduce him and welcome Dr. Pranav Garimella.
Thank you. Yes, well, thank you very much. This is always fun to come back to this summit. This is my second year here, and despite my talk last year, we said no, we want you back. So I'm excited to be here. As a nephrologist, I see a variety of patients in the outpatient setting, in the inpatient setting, and we often do dialysis as a life-saving modality. And that's where my first interactions with trying to understand what the effect of climate on health and the kidney health specifically was, and what the effects of how we take care of these patients affects the climate. And so that's what I'm hoping to talk about today in my talk on heat, climate health, climate change, and kidney health. So this is a map of India, and that red state there is where I grew up back in the 80s, 90s, and even into the 2000s. And those fields and those villages are from where my grandparents grew up. And we'd go visit them. We'd go visit my family that lived out there and still lives out there during our summer vacations. We'd go grab, coconuts from those trees and hang out in those fields. But outside of that, I never thought much about, how I connected with that or what the health was or what the people living there experienced. And I'll come back to why this plays a role later in my talk. But for the next 40 minutes or so, I'm going to give you a very high-level overview of what the problem is with kidney disease. Why are we concerned about it? How kidney disease affects people everywhere around the globe, and perhaps how it specifically affects people who are disadvantaged and don't have access to healthcare, like a lot of other conditions. We'll talk about why kidney disease affects the climate and how we manage kidney disease has significant impacts on the climate, and perhaps close out with things that are being done, not necessarily in the United States, but elsewhere that we actually need to embrace and perhaps think about as well. So let's talk about kidney disease. I don't know how familiar any of you are with kidney disease or how familiar all of you are, but it is a huge health problem. It is, in fact, one of the most common conditions as people age. We believe right now that about 10-15% of adults over the age of 65 actually have some form of chronic kidney disease. Dr. Castellanos, good to see you. We have approximately 1 in 10 adults in the United States probably who have kidney disease. And this is probably still underdiagnosed and underreported. And it's more prevalent in older people, women, it's underdiagnosed often, people who have diabetes. And as the population ages and obesity increases, kidney disease will increase too. In fact, it's already the 5th most prominent cause of death in the country. And this is not just true of the United States, this is true worldwide. In fact, this bar here represents the prevalence of kidney disease in 1990 in the blue, 2016 in red, and the predicted prevalence of kidney disease worldwide in yellow by 2050. You can see here that the prevalence of kidney disease is going to exponentially increase, especially so in developing countries. And we'll talk a little bit about why that may be. The problem with kidney disease is not just that it's common, it's actually incredibly expensive to manage. So kidney disease is a high resource utilizer. To give you an idea, look at that triangle on the right first. You've got about 40 million people who either have 1, 2, or 3 risk factors for kidney disease. About 18 million people in this country right now who are diagnosed with some form of kidney disease, and a very small fraction, only about 500,000 or 0.3% of the population that actually has kidney failure needing dialysis. But if you look at how much they cost, that 0.3% actually takes up 7% of Medicare's budget. This $47 billion from 2 years ago is now $51 billion as of 2024. It is a huge cost to everyone's taxpayer dollars. And you can see where the vast majority of the research dollars are spent. They are spent on ending kidney disease, in treating dialysis, but not really in the root cause of preventing kidney disease, where we should be spending a lot of that money. And that brings me to, why is kidney disease and heat and climate change connected at all? Well, as we know, climate change is complicated. And over the past decade, really, our understanding of the relationship between these environmental factors and kidney disease particularly has increased rapidly. You've got all kinds of impact that climate change has. You've got direct impacts, whether that's through heat waves, fires here in California, floods in Florida and Texas, and altered air quality. We've got indirect sources, infectious diseases that occur. We've got changes to crop and crop yield. We've got people moving away. We've got displaced populations in conflict. And all of these can occur due to climate change, as we see it happening worldwide. And together, these are probably the greatest threats we have to public health right now. And all of these, I'll show you on this graph, contribute to the development of kidney disease. As temperatures rise, as people get dehydrated, as they're working outside more, as their blood pressures get affected, as their ability to maintain a core body temperature gets affected, they have sudden changes in kidney function, what we call acute kidney injury. And even if this gets reversed, the number of times that they go through these cycles, especially farm workers, construction workers, people who don't have access to proper shade and cool temperatures on a regular basis, they end up getting chronic kidney disease. Most people don't even know that. Unlike conditions wherein you have a stroke or a heart attack, where sudden pain or change in clinical courses make a diagnosis a little easier, most kidney disease is undetected. Unless, of course, you have a kidney stone. Because I've heard that passing a kidney stone is the closest thing a man can experience to childbirth. I've never passed one. I don't, wish it on anyone. But again, kidney stones are getting more common as well. And this is more common, as I'll show you, in areas where the temperatures are rising faster than others. Of course, as we industrialize, as we lose more green spaces, as particulate matter increases, that all increases risk of cardiovascular disease, cardiometabolic syndromes, and that ties in with kidney disease. This is a map of the stone belt across the world, and it's literally a belt because it fits right across the middle of the world. And you can see this prevalence is really high in Southeast Asia and East Asia and Australia, and even in the southern United States and Mexico. And again, this has to do with temperature. 10 to 15% of the world has stones at some point or the other. And we know that increased heat is conducive. People don't drink enough water. Their urine is more concentrated with these stone-forming salts, and they end up with kidney stones. And you can see this is actually a graph of stone prevalence by men and women. The top bar is men. Kidney stones tend to be a little more prevalent in men than women. But on the x-axis is the mean temperature in Fahrenheit. And you can see as the temperature increases, the prevalence of stone also increase. And this is going to be true. This is actually a really nice predictive model that was developed showing the prevalence on what the stone belt looks like in the United States. The yellow band is the year 2000. The orange band is where it's going to be by 2050, and the red band is where it's going to be by 2095. So you can see that the stone prevalence belts are actually going to move further north as temperatures change. And we know this not just in the United States, but in Asia and Africa, and especially in the Middle East, where temperatures can often be over 100 to 110 Fahrenheit on a daily basis. In fact, those are like the stone capitals of the world. But it's not just stone. It's actually significant damage to kidney function that often occurs with temperature. This is a really nice study done in the UK where they looked at over 1 million patients who were hospitalized. So this is probably already being underreported because these are patients who had to go to a hospital and have a diagnosis of having sudden acute drops in their kidney function. And because it's the NHS and they can actually pull data on every patient seen in their single payer system, they actually mapped every episode of an ER visit or a hospitalization for acute kidney injury back to the postal code for where the patient lived. And then they mapped that to the temperatures that week and the 1-2 days before and the 1-2 days after. And what they found was that the daily maximum temperature in an area correlated strongly with the risk of patients ending up in emergency rooms for acute kidney injury. And after using a whole bunch of multivariable analysis, they found that any temperature rise above 28 to 30 degrees Celsius was really associated with an increased risk of kidney injury. And this is in the UK where temperatures don't even get very, very high for long periods of time. So you can imagine what the risk of this is in people in developing countries where they don't have access to the same cooling, air-conditioned areas that may be there in developed countries, and where agricultural and construction jobs may be far more common. But again, it doesn't affect everyone the same way. There are actually certain populations that are highly vulnerable to getting kidney injury. And you may have seen this in the popular press, that chronic kidney disease is poised to become the black lung of climate change. And chronic kidney disease is defined as having kidney disease for over 3 months. The problem is no one really knows when their kidney disease began because no one's getting blood tests, right? Like diabetes, like high blood pressure, kidney disease is a silent killer. Nobody knows they have kidney disease until it's far too late. And if you just look for chronic kidney disease and developing countries in the popular press, you will see a host of scary headlines. Deadly kidney disease linked to climate change. The silent massacre killing El Salvador's sugarcane workers. The killer stalking Sri Lanka's men. Yes, these are meant to get people to read the articles, but they're not actually far from the truth, unfortunately. Kidney disease in these populations is incredibly common. Unlike what I told you, where kidney disease is common in people who are the elderly, people who have diabetes and other risk factors, these are young men who are dying from kidney failure worldwide, working men who are providing support to their families. And so we had no idea why this was happening. And so we called it chronic kidney disease unknown, or CKDU. And if you look back and map where you see the CKDU, you'll see that it's very common in Central America, El Salvador, Nicaragua, Honduras. It's common in Northern Africa. It's common in Sri Lanka. It's common in Southeast Asia and in parts of India. That map where my family grew up, where all those coconuts workers used to give us those coconuts that I grew up during my summer holidays having, is actually a hotbed for chronic kidney disease in India. But what makes it different? Typically, we think about kidney disease as being caused due to diabetes, high blood pressure, cystic kidney disease. I treat a lot of cystic kidney diseases or conditions like lupus and other immune-mediated diseases. But CKDU is different. There's no diabetes. There's no hypertension. There's no protein in the urine. These kidneys are just inflamed sometimes. The structure of the kidney on the outside is completely normal. And these are affecting young men. So they don't fit the typical profile of what we think people with kidney disease should look like. And in fact, when we look at it, we'll look at the association of different job profiles, and whether or not pesticides are used. Even pesticides aren't really associated with kidney disease as much. So what is? Guess what? It's heat. These are graphs looking at kidney disease hotspots worldwide. You can see sites of epidemics in Central America, and you see the average temperature, daily temperature. The red is 32 to 33 degrees Celsius. So we're talking about temperatures in the 90s to 95 degrees Fahrenheit where people are out in the fields working. The same thing with Sri Lanka. The map of India on the right is actually the average number of heat wave days wherein the temperature is over 42 Celsius. And you can see that those states where I grew up in the north, they on average have 8 to 10 days of official heat waves, but people are still out there working because they have to. And looking at some of this data from Central America, people have checked what is called a wet bulb globe temperatures. For those of you in the field, you know that this is a combination of the dry bulb, a little combination of what we actually feel, and the black globe temperature to get an estimate of what the closest felt temperature is. And you can see on the graph here on the left, the bottom is actually the time. You can see this is at about 6 to 7 o'clock, and this is going up to noon. And the threshold red line that I've drawn is the line that limits OSHA based on the United States guidelines to where work should be limited to 75% work and 25% rest. And you can see that by 9 a.m. already, the temperatures have soared well beyond that limit. And in fact, if you look at these temperatures here at 11 o'clock, OSHA says that ratio of work to rest should be 1:3. So for every 15 minutes that you work, you have to rest for 45 minutes. How feasible do you think that is for workers in sugarcane fields? Nobody's going to get work done. They're not going to get paid. They're out there working in these fields, burning the sugarcane, cutting it down, and actually exposing themselves to more heat. And so this heat stress, water shortage, and exertion all lead to several factors that lead to kidney injury. There's breakdown of muscle. There's increase in their tonicity of the blood, how thick their blood becomes. The blood pressure can go up. And if they get too dehydrated, the blood pressure actually goes down. They get kidney stones. And all of them end up causing small amounts of kidney damage on a daily basis that over months and years accumulate to cause chronic kidney disease. There's no treatment for it. There's no treatment because the stimulus causing it is really heat exposure. Right. So what can be done? Well, it seems simple. You replace those fluid losses. You prevent their body temperatures from really rising rapidly. And maybe if they need some supplements to keep their electrolytes in check, you can do that. Make sure that they have adequate water in their fields. Make sure that there's actually shade. In fact, OSHA recommends for construction workers to have air-conditioned areas after certain work periods. Avoid high fructose beverages. Everyone thinks that they're repleting themselves with electrolyte drinks that are filled with fructose. In fact, we know that this actually causes more kidney disease when people are exposed to heat. Our bodies don't need that amount of fructose that we drink. How many of you have heard of the World Health Organization's oral rehydration solution, right? It's ORS. It's been used for cholera for hundreds of years. That's really the best solution there is. And you can actually translate some of that into clinical work wherein we see patients in Southern California and Mexico or our workers out in Imperial County, and we can provide them with some guidance. We can assess hydration status. We can provide them with tools to understand how to prevent dehydration, recognize signs of low blood pressure, maybe understand how to monitor their blood pressure and change some of these medications. We put people on a host of medications which are generally good, but sometimes they can actually cause kidney injury when they are sick or when they're dehydrated. So provide tools, advocacy, what we're doing here, what this entire community is about, making sure that people have access to knowledge and resources to take care of themselves and their surroundings. Maybe create a heat action plan. And I didn't know what a heat action plan was until last year when I actually started looking into this. Pediatricians have been doing asthma action plans for a long time. They really prepare their patients well. What happens? What are the steps you need to take if you're having an asthma attack? Similarly, you can actually have a heat action plan. And this, I've never seen it in play, but apparently it exists. So I'm hoping that, we as a community can start providing this to patients. How do you stay hydrated, especially if you're a construction worker? How much water should you drink? How do you adjust the medications? What are the signs of heat exhaustion and heat stroke? And when to see a clinician if your condition deteriorates. So this is something we can actually provide as a printout, as a handout to patients we know or to people who are probably going to be high risk of developing kidney disease. But it isn't just the environment that affects the heat. We do stuff to the environment too. Entire kidney care communities are affected also by what happens between the climate and our interactions. Dialysis, for those of you who don't know, is a life-saving treatment that happens at least 3 times a week. At least. People need to go to a clinic, they get hooked up to a machine for about 4 hours, get a treatment, and go back. So it's about 6 hours of their life, 3 times a week, that is spent going to healthcare facilities. You need water, you need electricity, and you need space. Some of you here in this room are not old enough to remember Hurricane Katrina. It was about 20 years ago now, where New Orleans pretty much got wiped out. These are pictures from Hurricane Katrina. And those are pictures from dialysis units in New Orleans. Hurricane Katrina closed 94 dialysis units in and around New Orleans. And even 2-3 years later, most of them never opened. What happens to these patients? They get displaced. Nearly 3,000 patients were treated in dialysis units that were closed due to Hurricane Katrina. They had to go elsewhere. Dialysis, remember, is life-saving. Maybe 1, maybe 2 sessions people can get away. Anything beyond that, their risk of dying is really high. And we know that. This is data looking at people who have kidney disease who are exposed to hurricanes. Almost 200,000 of them were exposed to 27 hurricanes in a 20-year period. And the risk of dying was about 13% higher, and it was greatest in the first 2 to 3 weeks after hurricanes. Again, you can see this graph here is the number of days after a hurricane, and then you had your risk of death. People die within that first week, really common. So making sure that these vulnerable populations are attended to during the time of crisis is critical. It's not just that. Even kidney transplants were lower after Hurricane Katrina because transplant centers closed. Dialysis patients were unable to get to treatments. And if you think Hurricane Katrina was too far away, last year we had Hurricane Helene. I am still dealing with the fallout of Hurricane Helene. Believe it or not, all or 60% of IV fluids that we use in most hospitals are produced in one factory in North Carolina. One factory that got taken out by Hurricane Helene. So what does that mean? We have patients who are not able to get fluids for dialysis. Dialysis centers were rationing fluids. Patients who were doing home dialysis could not get their supplies, so now they had to come to in-center and hospitals and emergency rooms for dialysis. And we actually have solutions that have stopped production since then because that facility could never ramp up. And I am still getting product from Mexico and the UK right now, as of today, this week. We've had to change all our order sets to account for these products because we no longer have the ability to make this because apparently they were the largest producer again. So when we think about how we're building our infrastructure, where we're putting our factories, whether we need to diversify, whether we need to centralize, we need to understand that one environmental episode like this could have a devastating impact on the way we treat patients. But again, like I said, it's not just the environment affecting kidney care. We will affect the environment too. And it's official. 2023 was the hottest year on record. 2025 January, from what I understand, is actually the hottest January on record ever as well. So we're definitely getting warmer. That little dot there, you can see that this is mean average temperature rise between 1991 and 2020. We're somewhere there in San Diego, so we might not be experiencing it, but the world around us is definitely melting. And you can see here the high emissions from greenhouse gases that are predicted and the effect that they'll have on temperature. The problem is we have a huge footprint in the healthcare sector when it comes to contribution to greenhouse gases. In fact, globally, 5% of the greenhouse gases are from healthcare emissions. And because we're the United States, we have a much larger footprint. We're up to 10%. In fact, if US healthcare was a country, we'd be 13th in the world. Just the healthcare sector. That's how much greenhouse gas we produce. And you can see in comparison, the greenhouse gas in tons of carbon dioxide emissions per capita in South Asia is like 0.03 to 0.5 compared to 1.65 tons here. Exponentially more greenhouse gases here. What does that mean for kidney care? Remember, I told you kidney care is high utilized. So, one dialysis session, that 3-4 hour session I told you about, we need about 395 to 400 liters of water. That's a lot of water, one session. This includes the pure water we need to create for dialysis, the osmosis, the discard water, everything. An average shower is about 17 gallons of water. So 95 gallons for dialysis, 17 gallons for a shower. And so for those 550 to 600,000 patients a year, we probably use about 6.3 billion gallons of water per year for dialysis. Now, if you did some math, that comes out to about 370 million showers a year. So, this was supposed to be a video. This is actually our UCSD dialysis unit, wherein the reverse osmosis water actually runs all the time down into a drain. This is water that can be used. But just to give you a context, that water that I said, 370 million showers, it's enough for everyone in the US to take one shower. Everyone. That's how much water we use. But it's more than water. This is one of our techs in the dialysis unit holding that entire kit up once we've taken it down from a patient. And it's not just one patient, right? We have 18 patients each shift, 3 times a day. We do this in our unit, and each shift we generate about 2.5 kilos of waste per patient, 13 treatments per month, 12 times. That's a lot of weight. In fact, we actually have one of your colleagues who has a poster this afternoon who's doing a project with me. We're trying to understand how much of this is actually landfill, how much of this is going to the incinerator, and how we're doing in terms of actually separating this out. Because waste that goes to the incinerator costs about 5x what it should be. But there is no differentiation necessarily in these units. People are just putting it in because they're like, oh, was there blood on that tube? I don't know, let's just throw it in. So things get very, very expensive. There are no recycling bins in dialysis units. They were taken away. So we're trying to figure out if we can get them back now. But again, each session of dialysis per patient is 7 tons of carbon dioxide. That's a lot of emissions per patient. So dialysis may be low volume, only 0.3% of the patient, but it sure does punch above its weight when it comes to cost and waste generation. Worst part is, we've never even bothered about this in the United States. Only last year was the first time when somebody even started to look at this. And there's just so much variability in how dialysis is practiced. This is 15 dialysis units in Ohio. And what we know is that there is a lot of variability, 3x variability in usage in Ohio in terms of waste generation and emissions. There's no way I can compare myself here sitting in San Diego to somebody who's doing dialysis in Seattle or New York. But this is what we should be doing. We should be understanding how we are generating waste, how we're managing it, and standardizing it so that we can actually have a lesser impact. The emissions from a hemodialysis facility can actually power 93 homes on average a year. That's a lot. So we need more benchmarks. So what are people doing? Clearly, we're not doing enough. But there are people in other countries who are doing stuff. In the UK, for instance, they actually have a fellowship program. They have several fellowship programs, including a green nephrology fellowship program that has 2 nephrology fellows they train. They do projects on understanding how to reclaim water, how to reuse some of the dialysis machines and their parts, and how to reduce the carbon dioxide emissions. And these are just some of the pilot initiatives that they have. And based on their calculations right now, if they can actually get most of these initiatives, they have about 20 initiatives that they think are feasible. And if they can get these initiatives in place, they will save on average 11,000 tons of carbon dioxide. We have no estimates right now in the United States. So this is where we really need to step up. I think we can reduce the amount of dialysis need. Of course, trying to reduce the impact of dialysis is one thing, but if we can reduce the number of patients who end up needing dialysis, that's a completely different story. Are we reusing the water? We could definitely do that. Are we recycling the dialysate? Again, these are not theoretical concepts. This is a vegetable garden grown on the site of dialysis units that is used for communities that live nearby. Remember, this is actually pure water. It goes through 2 carbon tanks and a reverse osmosis filter. This is technically potable. You could drink and you'd be fine. But yet you saw that it runs into the drain here in San Diego. This is a hospital in Australia that has taken the water that is coming out of the reverse osmosis, sent it back up to the tank in the hospital, and sends it out to all the wards to use for hand washing and for actually watering all their plants. So there are a lot of things that can be done. My colleagues in Michigan have actually done this, and they are saving a lot of water. It just needs a huge push and effort. So we can repair these machines. We can make them last longer. We've got machines that have been in space since 1990, but I cannot get my dialyzer to last more than 2 months or 3 months sometimes, and that's frustrating. So we really need to do a better job of using the machines we have. How do we use the circle of cradle to cradle model, right? How do you create the machines? How do you reuse them? How do you break them down? And how do those parts become available for use for other dialysis machines? And technical waste should really nourish this technical cycle. We've always thought about biological waste being compostable and being useful for the next cycle, but we need to do this for technical waste too. So what are we doing here at UCSD? We've recently had a certification process through our sustainability group where we got our dialysis units certified as silver status, but there's a lot more we can do. We can try and reduce waste, which we're trying to do. We're developing methods to reuse plastic. We are also understanding how to segregate this waste, make sure that, the sharps are all going in the shops, none of them are going in landfill, and that we're actually not accidentally dumping recyclables and landfill in incinerated waste because it gets expensive. And so I'll close out with just one real slide, 2 slides here that, highlight how complex this connection is. We know that heat causes kidney disease. We know that heat causes kidney stones. We know that infections are caused because of famine and floods that are related to climate change. And we know that industrialization causes kidney disease. But we're contributing to that as well. We really need to understand how we can lower water use. How can we promote patients to dialyze at home through more effective and water efficient mechanisms? How can we use medications that are perhaps oral and less injectable so we're not generating as much plastic? How do we keep patients from progressing to end-stage heart disease, kidney disease, so that we actually have less resource utilization? And there are plenty of opportunities here. It starts with something as simple as segregating waste. You could go into recycling, using better gas. We can, look at emissions and electricity. But really, how I see this playing out is more like Russian dolls. I think we are still thinking about stuff down there, the smallest one. How do I manage dialysis waste? Can I change my prescription? Can I use less water? But really what we need to be thinking about is, why are people even getting here? Can I move this further up? Can I keep people off of dialysis? What do I need to do to keep people off of dialysis? How do I keep them healthier? How can I prevent chronic kidney disease? How do I go out into the community and prevent that person who's being affected by heat, who's doesn't know about their disease and going to end up needing dialysis from actually getting there? How can I interact and educate people about the environment so that they can take care of their environment and not contribute to significant climate change there? So again, there's a lot to be done, and I think we're still working in these areas here in nephrology. I think we really need to move up further into pre-dialysis care. And I think I'll go out on a limb here and say this isn't specific just to nephrology. This is probably true across the spectrum of healthcare where we're looking at saying, if we can actually understand, educate, prevent disease early, detect disease early, we probably will have a much smaller footprint on the environment later on. And with that, I will stop and thank you again for your time. I really appreciate it. Happy to take questions.
I just want to thank Dr. Garimella again for your amazing presentation. We have like 8 minutes until the end of our breakout so you can answer some questions if you guys have any.
He has PKD, polycystic kidney disease. Thank you. Hello, hello. And when you order that, there is and why and others think about and my people the child and so of course my brother-in-law the one application it's very but usually with in about stuff you don't know that it's I was wondering, I think look at relative genetics as well as China. I mean, as a
Yeah. So, thanks for sharing that about your family member. Again, inherited kidney diseases are tough because unlike people who don't know them, it comes with a lot of baggage, it comes with a lot of emotional stress. People have seen their family members and stuff, and so there's a huge component to it. Yes, to answer your second part of the question, yes, there is. There's actually data out of large cohort studies showing that people who have a genetic predisposition to develop certain forms of kidney disease, especially there's a condition, there's a gene called the APOL1 gene, which disproportionately causes kidney disease in people who have West African ancestry. And in these patients, what we see is that interactions with excess particulate matter, or the 2.5 million particulate matters, they actually cause rapid progression of kidney damage in them. Heat definitely disproportionately affects them, but there is particulate matter. We know that water associated water that is tainted with lead or mercury, for instance, disproportionately causes diabetic kidney disease progression. So, long story short, the connection between genetics of disease and progression is well established. It isn't the same across the diseases. Some of these conditions that cause proteinuria and loss of kidney function through some mechanisms in the filter of the kidney are more susceptible to environmental toxins and rapid progression of disease. Yeah, thank you. You had a question. Thank you.
Then disease harm. One of those like taking hold or very challenging kind of what's been a thought college. And the last thing like you can take from over that and right, move on.
Mm-hmm.
Work. That's what being broad.
So, unfortunately, yes, it does come at a cost of, looking to monetize things that exist. People have made a lot of money on dialysis centers, and so there's historically been a focus on building that out because there is reimbursement tied to it. And in our country, because everything is essentially tied to reimbursement, you have to go back and say, okay, where do people want to invest their dollars? And it turns out that, because dialysis is federally reimbursed, dialysis is kidney failure is one of the conditions that people actually qualify for Medicare for, unlike everything else. So yes, we don't have enough of infrastructure still on the preventative and the environmental and the interactions aspect of it as we do on managing the complication. Yeah. Sorry, that's a couple questions. Sorry, you had a question. Hi.
And so one of the things yeah. But when we
Right. So right now, actually, there is no policy within the dialysis sphere to improve utilization or decrease costs. It just doesn't exist. When you go to the websites of large dialysis organizations, there are two companies that control about 75% of all dialysis. They tout the fact that they have, water reclamation and, use of solar and stuff. But really, some of the things that drove the costs down for them were the fact that during the pandemic, we didn't have access to a lot of solutions, so we had to ration them. What we found is that decreasing the blood flow, decreasing the dialysate utilization actually does not have an impact on patients. Actually, they do completely the same. So people have used that as how they have saved costs and saved water and stuff, but I don't think it was really the effect on the environment that they were thinking about. We're trying to do this, for instance, to upgrade some of our machines because now our water wastage use was almost for every liter of dialysate produced, we were previously wasting about 3.5 liters. So we've got newer reverse osmosis machines that actually reutilize this, and we only have about for 1 liter of dialysate, we only waste about 2 liters now. So there's about a 30% reduction in the water usage, for instance. The problem is that anything of that scale actually requires a fair bit of investment. To actually have a reusable new RO system costs about $750,000. And that's a non-trivial investment from healthcare. So we're trying to work around some of the things that have relatively lower cost in terms of education, in terms of identifying timelines, decreasing waste rather than asking for something that costs almost $1 million. But really, if we need to move the needle on this, we have to see where the costs are, and that is improving the machines, getting newer machines that are more user-friendly, that use less electricity and less water. But coming back to what else are we doing? We're actually trying to get people out of in-center dialysis units and move them to home dialysis. Because home dialysis actually uses about a third of the amount of water. Nobody can use 400 liters of water per dialysis session at home. Your water bill will be through the roof here in San Diego. So at home, they can, get away with about 30 liters, 40 liters of water per session. So 10 to 15 gallons. So they do it every day there. Well, why don't we do it that way here, in dialysis units? Because Medicare said we'll pay for 3 times a week. And so we do it 3 times a week, and we get 4 hours, and that's all you get. That's the bare minimum that Medicare will pay for. So nobody else cares for anything else. So yes, so moving patients away and using newer technology is probably the best way to actually move the needle on costs in dialysis. Question? It's a great question, and unfortunately, I don't know anyone. Do you know anyone who does education up there, like teach related workshops or anything? I don't. Yeah, it is. But no, but I mean, I think that there are opportunities to work on things, specific topics, the heat-related blood pressure, cardiac and stuff like that. I'm sure there are people around who'd be willing to provide time and resources and education, but off the bat, I don't know anyone at UCSD who's actually doing it. Cool. Well, thank you. Over.
Yeah, again, in one great.
Uh, Absolutely. And great question. So the fructose is shown to be toxic to the kidney. There's no question that that's been shown multiple times. Doing studies in these populations, any kind of control trials is near impossible just because of the logistics of providing it, whether or not they'd be working the same every day, and how do you measure the outcomes and stuff. There are groups in Texas and Florida right now, some research groups that are working on simulating this. So they actually bring people in for 2 days at a time, keep them in a controlled hot environment as though they will be working, including day and night temperatures. And they're looking at what happens when they give them some of these solutions. And what they see is the biomarkers for kidney damage and heat stress are much lower when they're given non-fructose containing solutions. So typically WHO ORS, that is what they're using, or some combination of it. But there are no trials or large data out there to say that this is better. What we do know, unfortunately, is that the fructose containing syrups, not just bad for the kidney, they actually increase the blood pressure and the obesity risk and all of that. And again, they are cheap, they're marketed, they're pushed to these populations as, being electrolyte drink, right? So if you flip over those things and look at the amount of electrolytes, they just have to be measurable to be called an electrolyte drink. It doesn't really matter what the concentration is. So the concentration varies significantly. And just because, again, ORS has to be made in water, it has to be bottled. Pedialyte is probably the closest to what ORS can be, but it's not sold in your big box store. You don't get a 12-pack of Pedialyte, in your stores. And so I just think the education around what is bad is inadequate right now, honestly. But coming back to your question, no large study proven it. Preliminary data shows that from a biomarker perspective, it's much safer and reduces kidney disease risk. But again, these are 2 days, right? I can't keep someone in for 6 months in a heated room. So does 2 days extrapolate to 6 months of work outside? We don't know. But Imperial Valley is a high risk area. Just so much. And there's no data actually in California. And you'd be surprised at how unions and other organizations that pay these people have tried to push back against legislation for, regular breaks and shade and stuff, right? Because it affects work, it affects cost, it affects production. And so it just blew my mind about all the hurdles that you have to go through to get something as simple as shade and water and air conditioning.
Thank you again, Dr. Garimella,
Thank you.
for your presentation. We did come to an end to our breakout session. I believe the next is going to be lunch until 2 p.m. And so feel free to use the restroom, grab something to eat, and we have some tabling events, and you can socialize with each other. Thank you so much.